So your patient had a bad night and is now on ECMO. Let's talk about VA ECMO physiology and what's important to know before you present your patient on rounds. This video is for frontline providers and assumes you have some knowledge of ICU concepts like afterload and minute ventilation. Also, every hospital sets up their ECMO circuit slightly different, so learn about what you are working with from your ECMO specialists. ECMO is a form of partial heart-lung bypass and is the maximal amount of support we can give a patient in the ICU. The machine looks complicated, but in reality, the device only requires a few things: cannula to take blood to and from the body, a pump to move the blood around, an oxygenator to exchange gases with the blood, and a heater to warm the blood before it re-enters the body. In current circuits, the pump, oxygenator, and heater are combined in one unit, but we need to consider their functions separately. When thinking about the physiology of the ECMO circuit, we can relate each part to an organ in the body. Let's start with the pump, which is doing the work of the heart. At the time of this video, most ECMO pumps are centrifugal pumps, meaning they spin around really fast to drive blood through the circuit and back to the body. The goal of the pump is to achieve adequate output, usually somewhere around 100 to 150 milliliters per kilo per minute for children. But we can't dial that number in. We can only tell the pump how fast to spin in RPMs. And a set amount of RPMs will not get you a set amount of flow, because those things are not in a linear relationship. This is because, like the heart, the pump is sensitive to both preload and afterload. For the heart, preload is the volume of blood returning to the ventricle, which often is impacted by the central venous pressure. Same with the pump. While spinning, the pump generates a negative pressure to pull blood into it. There is a limit to how much negative pressure it can safely generate. Too negative of a pressure, and blood can start to hemolyze, or it can suck the walls of the atrium into the outflow cannula. To stop this from happening, the pump will slow down or even stop if the pressure becomes too negative, dropping the output provided by the machine. The most common reason for this is low blood volume, either due to bleeding or overdiuresis. This can be improved by giving volume back in the form of a fluid bolus or blood transfusion. Poor venous cannula position can also impact this pressure and limit flow. Continued problems with negative pressures may require revising the cannula position. The pump is also sensitive to afterload, which is how much pressure it's having to generate to pump blood out of the circuit into the body. The higher the afterload to the pump, the less flow there will be for a set amount of RPMs. High afterload can be the result of a couple of things. It may be a mechanical issue, with cannulas that are too small for the flow you want, or not well positioned. Or it can be a patient issue, with high systemic vascular resistance and hypertension. Vasoconstriction is common after cannulation onto ECMO due to the inflammatory response caused by the circuit, and medications like epinephrine the patient received prior to cannulation. If you are having trouble flowing due to excessive post-pump pressures, get the blood pressure down with vasodilators. Since we can't dial in an output, we have to measure it with a flow sensor on the arterial limb of the circuit, which will give you milliliters per minute going to the patient. This is a good time to remind us that a good blood pressure does not equal a good cardiac output. A patient can have a high blood pressure due to high systemic vascular resistance and still not be getting enough blood flow to the organs. Now let's talk about the oxygenator, which not only oxygenates the blood, but removes carbon dioxide, CO2, just like our lungs do. Very simply, the oxygenator has a membrane with the patient's blood on one side and the sweep gas on the other. The sweep gas has a higher concentration of oxygen than the blood, so oxygen diffuses into the blood across the membrane. The sweep gas does not contain CO2 unless it's added in, so CO2 diffuses from the blood to the gas. We need to set the sweep gas to maintain the patient's oxygen saturation within goal and the CO2 at a level that gives us a reasonable pH. How we do this is different for oxygen versus CO2. If the patient isn't on ECMO, we achieve appropriate oxygenation by adjusting the FiO2 on the ventilator. CO2 in the patient's blood is manipulated by changing the patient's minute ventilation, by changing the rate or tidal volume on the ventilator. There are similar concepts for patients on ECMO. We increase oxygenation of the blood by increasing the FiO2 in the sweep gas, just like increasing FiO2 on the ventilator. For CO2, the rate of the flow of the sweep gas is equivalent to minute ventilation on a ventilator. Sweep gas is measured in liters per minute. Increasing this flow will increase the minute ventilation, and thus remove more CO2 from the blood. The last component to talk about is the heater. As the blood flows through the cannulas, it cools down, and without a heater, the patient would become hypothermic. So the blood passes through warm water for which we set the temperature to maintain our temperature goals for the patient. This means we control the patient's temperature, and the patient won't get a fever if they are infected, making it more likely that we may miss the early signs of sepsis. But you can track the temperature of the water bath. So if that is dropping to maintain the same patient temperature, you may have a problem that requires antibiotics. Now, a patient on ECMO is going to generate a lot of data, and no one is interested in hearing you repeat all those numbers on rounds. What's most important is change. Has the FiO2 to the oxygenator increased while maintaining similar patient saturations? You might have a problem, such as clots forming in the oxygenator. Flows dropping due to negative pre-pump pressure, probably a problem. Lower water bath temperature, problem. Changes can also signal patient improvement, such as a lower FiO2 need signaling an improvement in lung function. Every patient on ECMO is going to have different support needs based on their circuit and cannula size, cannula location, anatomy, and native cardiac and lung function, so there are no normals for these values. Watch the trends so you can intervene before a small problem becomes a big one.